Continue with Dr. Bratis, a consultant cardiologist at the University of Manchester, and he will present a talk about functional perfusion and tissue characterization, a very important thing in aneurysmatic and ecstatic coronary artery disease. Dr. Bratis, thank you for being with us.
Thank you very much for your introduction, and it's a real pleasure to be part of this comprehensive virtual conference for another year. Congratulations to Sophie for organizing this. So, as a continuation to the previous comprehensive talk from Dr. Androulakis on coronary aneurysmal disease and ectasia, we'll discuss just after the extracoronary features, cardiac features, focusing on function, perfusion, and tissue characterization in this patient population. I will try to avoid any overlap. However, let me please highlight a few basic information. So we are talking about aneurysm and ectasia based on the localization, extent of the coronary anomalies, and then based on their size, we have small, medium, and giant size. And this condition can be complicated with thrombosis, embolization, or even vessel wall rupture. Now, as it was mentioned, this is, in fact, coronary aneurysm is the common pathophysiological pathway of several conditions, different etiologies, including atherosclerosis in the majority of the cases, infectious, connective tissue, autoimmune conditions. In this presentation, we'll use Kawasaki disease as a paradigm, and we may be able to provide an answer to the question that was raised by Sophie and Manos just before on the metric analysis of the vessel wall, of the coronary vessel wall. So Kawasaki disease is a generalized systemic vasculitis involving merely all arteries of small and medium vessels, involving merely all arteries of the body, but primarily the coronary ones. It is of unknown etiology, but an exaggerated immune response is seen in most cases. And it is the most common acquired heart disease in children. Now, it's a relatively new condition. It's been almost 40 years that it was first described. So the full spectrum of the pathophysiology and then the long-term consequences of this acute disease are not fully known. But since the early days, with the use of the echo and endomyocardial biopsy, we were able to describe and see that beyond the coronary artery involvement, the myocardium was also involved, with myocarditis being seen in the majority of the cases in the acute phase, but with a preserved function noticed on the long term, involvement of the pericardium, of the valves, and of the great vessels. So we are dealing with a pancarditis, in fact. However, despite the fact that all different anatomical cardiovascular structures can be involved in Kawasaki disease, the guidelines, the management propose that the management of the disease should rely, this is what the evidence suggests at the moment, should rely on the coronary arteries. So this means that risk stratification, follow-up management, but also treatment all rely on the presence of any and the significance of any residual coronary artery lesions. However, in those guidelines, it's also suggested that beyond the coronary arteries, the presence of any abnormal functional abnormalities, perfusion abnormalities, but also the presence of myocardial infarction or ventricular dysfunction do have a prognostic role and should be taken into consideration. Also, extra anatomical factors such as the young age at the acute insult, the short period from the acute event, and then potential inflammatory and genetic factors should be also taken into consideration when discussing about the long-term prognosis of Kawasaki disease. So there is an interest to discuss beyond the coronary arteries, and I'll start doing that with the function and fibrosis, which in the majority of the cases are examined simultaneously in the studies. So it may be interesting to discuss both at the same time. We know that from endomyocardial biopsy studies that patients with Kawasaki disease have some degree of myopericarditis in the acute phase, and that on the long-term myocardial fibrosis is detected. But ventricular systolic function in the majority of the cases is normalized if it is affected at the acute event. When discussing about the non-invasive approach for assessment of fibrosis in this but any other patient as well, then CMR is the only technique that can provide this information both at a macroscopic and at an interstitial extracellular level, depicting accurately any ischemic or non-ischemic pattern of fibrosis. With the use of a wide range of sequences, but for the purposes of fibrosis, of depicting fibrosis, focusing on the traditional late gadolinium enhancement sequence, which can offer images of different patterns of enhancement of the scar tissue. So the ischemic one on the left, subepicardial in cases of myocarditis, diffuse patchy pattern, particularly in the hypertrophied segments in hypertrophic cardiomyopathy, diffuse infiltration of the ventricles and atria in the case of amyloid, and then pathology of the right ventricle in the classic ARVC disease. And then with the application of more novel techniques, metric ones, so the information comes from what we measure rather than from what we see. Doesn't rely on visual assessment, with measurements that are suggestive of the underlying tissue properties. For example, at both ends, we have at the high end high T1 value suggestive of amyloid infiltration and infracted MI infarction, and at the lower end, the presence of fat, thrombus, and iron. It was already, there are studies on simultaneous assessment of the function and fibrosis in Kawasaki disease patients. Already back in 2006, Professor Mavroyeni did show that the presence of scar in patients with previous Kawasaki disease and residual lesions, the topography, so the anatomy, the scar distribution was related, of course, to the diseased arteries, and the presence of any dysfunction was seen only in patients who had, in fact, an established infarct. And this was confirmed later on by a Dutch team with a retrospective follow-up study over 11 years in patients with previous Kawasaki disease, in whom the ejection fraction was affected on the long term only in those patients with an established infarct, and normalized in the rest of them despite the presence of any myocarditis, any myocardial inflammation in the acute phase. But also, at the subclinical level, our team managed to demonstrate a few years ago with the application of CMR feature tracking, so sort of a strain analysis. This is a CMR-based strain analysis, where in patients with previous Kawasaki disease and preserved ejection fraction, we demonstrated that circumferential and longitudinal function were affected, irrespective of the coronary artery status, irrespective of whether there were residual lesions or not. Now, the application of metric imaging that was mentioned also as a question just before, the data are scarce. There are only few studies with contradictory results, which is not striking. It's a novel technique, when we deal with Kawasaki disease, we expect studies with only with a small number of patients. So it's not possible to have, we still gather evidence, we still try to understand the disease, and it's not strange that we end up with conflicting data. There is, I present here a small study with ECV analysis of so parametric T1 parametric imaging of the myocardium in Kawasaki disease patients in whom there was no particular difference, significant difference compared to normals. While on the other hand, and as we have already demonstrated, focal fibrosis was not uncommon. There are no studies, to my knowledge, and up to the point that I managed to look through the literature, there are no studies on metric analysis of the vessel wall in Kawasaki. In general, the metric analysis, parametric analysis of the vessel wall is quite challenging because, of course, of the spatial resolution. Let's move on to myocardial perfusion in Kawasaki disease. Kawasaki disease has got a distinct pathophysiology with gradual intima hyperplasia and media destruction leading to endothelial dysfunction, calcification, and possible thrombus formation, intraluminal formation. And there are sufficient studies with different modalities, including echo and nuclear ones, demonstrating the presence of visual defects, visual perfusion defects suggestive of ischemia, which do not forcefully correlate with the coronary anatomy status. For what concerns, so suggestive of microvascular, a degree of microvascular dysfunction in this patient population. And we do know for the epicardial part of that, so for patients who have residual ischemia at an epicardial level, that this is a significant prognostic factor for future events. So the majority, if not all of them who will experience MACE in the future, are patients with residual ischemia at baseline. When we discuss about myocardial perfusion, especially in children, there is an obvious advantage for CMR. We are talking about a technique, so we have to do with a modality that is non-radiating, is non-toxic, it's safe, it can be repeated several times, it's comprehensive, so at the same time, we can assess for all the different anatomical and functional features that were mentioned earlier in these two presentations, and with an obvious diagnostic quality advantage in terms of in challenging cases such as in multivessel disease or in cases with suspicion of microvascular dysfunction, or both when we have cases with possible mixed ischemia, epicardial and microvascular. For what concerns microvascular dysfunction, our team worked on that a few years ago. We analyzed patients with semi-quantification with stress perfusion, adolescents, Kawasaki disease adolescent patients, and we managed to demonstrate that mean perfusion reserve index was significantly impaired compared to normals. And this was irrespective of the presence of any persistent or regressed coronary lesions. And even in the same patients in territories which were subtended by normal and diseased vessels, the results were not much different. So global microvascular dysfunction on the long term in this patient population. This was confirmed with a more recent study, and I will complete my presentation with this study coming from Canada, where the authors, the group, applied a multiparametric examination of Kawasaki disease patients, including perfusion, metric analysis, mechanics, so strain analysis, and obviously function and fibrosis analysis with LG, but also with parametric imaging, as I mentioned. There were some interesting results coming out from this study. So fibrotic myocardial remodeling existed and extended beyond any infarcted tissue, but also beyond any residual significant coronary artery disease. And these changes were only partly explained by reduced microvascular perfusion, so by any microvascular dysfunction, which was confirmed, however. And the higher, the more significant the fibrosis, the diffuse fibrosis, fibrotic remodeling, and the decreased perfusion impairment, then the more affected the contractility was at a subclinical level, so impaired strain. The message that the authors proposed, and my message as well from this, out of this talk, is that when we assess a patient with coronary aneurysmal disease or ectasia, we should always take into consideration the extracoronary parts of that, the extracoronary aspects of the cardiovascular system, including any functional, even subclinical ones, and tissue or perfusion abnormalities. Thank you very much for your attention.
Dr. Bratis, thank you for your excellent presentation. You clearly described that Kawasaki affects all components of the heart. Vascular components, myocardial components affects the tissue level. And CMR is a perfect tool to do a complete assessment and follow-up of the patient. Would you agree that because this is an unusual situation, this patient should be followed in a referral center? First, this is my first question. And the second, what is the protocol for follow-up in Manchester for patients with children with Kawasaki disease?
So, thank you for your comments. Yes, I agree that these patients should be seen apart from the routine cardiovascular follow-up that they can have, assessment that they can have locally for reasons of, for practical reasons. Then they should have additional assessment at a reference center. These are patients, so we are talking with about a rare disease in practice, not because it's uncommon, but then in terms of specialized clinics, numbers are small, especially in countries like in the European countries, for example. So I agree that the management can be more efficient in reference centers. And then with regards to the follow-up management, we follow the guidelines. And this means the follow-up is mainly dictated by the coronary artery status and any residual dysfunction of these patients. So based on the coronary artery status, any known residual lesions, the time of follow-up is dictated.
Thank you very much. Are there any questions? No, I think there are no more questions. Thank you very much, Dr. Brady. Very insightful presentation. It helps us a lot for this unusual diseases. And we had an excellent round table for CMR from the basics and the specific uses in ischemic and non-ischemic heart diseases up to psychological diseases, and also the use of brain CMR, and more practically in patients with Kawasaki and vascular disease, which are very demanding patients. Thank you all for attending the session, and all speakers. Thank you, Sofia Mavrogianni, for inviting all these experts on this issue, on this table. Thank you. We have a break, and we'll come back for the continuation of the program. Have a good day.
Thank you very much.